Thank you for tuning in to Beyond the Abstract, a student-led physical therapy journal club. On today's episode, we discuss the concept of scapular stability. We attempt to challenge the common narratives associated with this concept, and we discuss what this means going forward in clinical practice. Thanks again for tuning in, and enjoy the podcast.
We doing it? There we go.
All right, everyone. One thing I do want to talk to you guys about that you both appreciate is Ray Williams squatting 1,080 pounds. Are you aware of that?
I was not aware.
Didn't he squat something close to that last year at the Arnold, or did he break his record?
He attempted 1,080 last year and missed it, and then he just made it yesterday. And it's if you get a chance, look it up.
Awesome.
It's insane.
That's absurd. Did you see, what was it? I don't know how to pronounce his name. It's like Half-Floor Bjornsson or whatever, the mountain.
Yeah.
Doing that, he broke his own deadlift record, but the speed that it moved off the floor and got to his hip is ridiculous.
Yeah, that was 474 kilos.
Probably, yeah. He's like, I was thinking about 500, but we'll save it for next time. And
Yeah, they had an event where I
Jesus.
think anyone who pulled over 500 or your equivalent to 500, they were going to win like $10,000 or $50,000, something like that. But I don't know if anyone did it.
Yeah, that's
Very crazy.
yeah.
What lifting stories do you have, John?
I don't really have any lifting stories right now.
Maybe some of your own?
Some of my own. I broke my cat's leg when I was dropping a deadlift once.
Jesus Christ, John.
Okay, just bring that up.
Yeah, so I was doing deadlifts in our barn. So when I lived back home, we had this really old barn. We had nowhere to set up actual weights except in the barn.
Mm-hmm.
I was like following this guy's program. He's like, "Oh, you shouldn't lower a deadlift because you might like throw your back out the way you're doing it or whatever." So I was just dropping them. I was not doing the eccentric part at all. And I had these pads set up, and it didn't drop. Thank God it didn't drop directly on the cat, but the cat was running by as I was dropping my deadlift, and I guess it like bounced partly and hit him like on his leg or whatever. And we had to take him in and get his leg like splinted or whatever. So
That's intense, man.
yeah.
I'm glad he's okay. What's his name?
His name, let's see, he actually passed away a couple years ago. That was Blaze.
Wait, hold on.
It's okay, John. I caught a clean on my throat this morning, so
And,
it's okay.
I mean,
It's fine.
It's okay to injure yourself, but not another. That's
yeah. No, you can't hurt animals, but you can abuse the crap out of yourself.
Shall we introduce the topic at hand? What is the topic at hand?
Oh man,
Scapulas, talking stability, talking instability.
Talking kinesia, dyskinesia.
What does that all mean?
Amnesia.
I think it means anything, man. It doesn't mean anything.
What
But
is it?
yeah. So we have 2 articles today, correct?
Yes.
We're going over 2 articles, and we've got starting out with a perspective paper titled "Critical and Theoretical Perspective on Scapular Stabilization. What does it really mean, and are we on the right track?" And this was written by McQuade, Borstad, and Oliveira. And who's got the second article?
Yeah, I've got it. It's a 2005 paper called "The Effect of Long versus Short Pectoralis Minor Resting Length on Scapular." I think this says Kinematics, but I don't have the rest of the title because it cut out. But that's what my paper says.
Let me see. I'll just read the full title. It's
You're good.
yep. No, you're right. Pectoralis minor length on scapular kinematics and in healthy individuals. And this was written by Borstad and Ludwig.
Right. I think it's worth pointing out that is a controlled trial, whereas the other paper is just like a sort of summary perspective paper, kind of describing some other literature on the topic and kind of offering their perspective on the topic of scapular stabilization. So that's kind of what we're going to be really honing in on.
Yeah, and credit where credit's due. This perspective piece I actually pulled from a blog post from Barbell Medicine, so you can find that on their website. And John pulled the second article that we're looking at as a comparison piece. And where did you get that out of?
Out of our textbook for one of our theory and practice class. So it's got it right here. Therapeutic exercise. It's a common text in a lot of PT programs. It's a edition before the latest, so it's not the newest one, but still used in class. So
Yeah, so the point being, we're trying to compare what is relatively current versus what is in the textbook and being taught in class. So, all right, let's jump into this. So in regards to this idea of scapular stabilization, it's something that I've heard on my clinical rounds a lot when I've done observations and shadowings. Scapular stability seems to be almost like a buzzword or a hot topic when it comes to shoulder health. What are y'all's impressions of what scapular stability is? Excluding this article, before you all read it, what was your impressions of it?
Yeah.
So my experience with it was it was presented as your scapula needs to be stable in the sense that it shouldn't move. It should kind of form a solid base where everything can move off of. Basically, if you're pressing, your scapula shouldn't wiggle out of the way any weird position.
Yeah, I mean, I think I would just echo that and say that it seems like the narrative is the scapula is supposed to be this sort of base of support, this anatomical base that is rigid and stays so that the upper extremity can move on it.
Yeah, I echo both of those comments, and I would even go further and say that it was my impression, at least, or maybe it was just me implying this, but I always attributed like scapular stability to sort of normal movement. But after having read this article, it seems that paradigm is questionable. So if we start off with this perspective paper, the authors actually open up with the statement: the notion that an unstable scapula is related to shoulder dysfunction and pathology is well accepted. But what the authors do a really good job of in this paper is sort of teasing out a couple terms that are related to the scapulothoracic joint and the shoulder complex in general. And before we really get to the nitty-gritty here, I think we should define some terms. So this article defines stability as a system's ability to return to an original position or state following perturbation, and they make the point that there's no variability in this. A system is either stable or unstable. And I would encourage y'all to go look at the reference that they have for that. It's an open access article. It's talking about spinal stability, but they do a really good job of clearly defining what they mean by stability. And, I think that was really helpful for us kind of trying to figure out what that meant. And in regards to the joint itself, when they talk about joint stability, a joint is stable so long as it doesn't exceed its physiologic limit, which poses an interesting conundrum with the scapula because, barring any trauma, the scapula never really exceeds its physiologic limit. So by that definition alone, it's an inherently stable joint. What are y'all's thoughts on that?
I don't have anything yet.
Okay. No, I mean, the authors point out that, we haven't gotten into this next term of robustness, but the authors definitely point out that, it could be viewed as sort of just this semantic argument, like what word to use. But I'll just read a section off the paper here. It says, we propose that the implications and assumptions associated with the term, stability influence the approach to patient care, and in that clarity versus ambiguity matters. So I just feel like, it's important that we do define these terms so we have like a sense of where we're going with treatment. That's not really answering your question. That's just kind of what I take on the term.
Johnny, you got anything?
What I'm kind of taking from it is basically it's just we can't apply just what we think of as regular joint mechanics to the scapula since it's not the same. And just as long as you have, as long as your scapula is moving and everything more or less, it's functional.
Yeah, I totally agree. We'll get into the term robustness in a second, but I want to talk about how stability has sort of become analogous to normal scapular movement. And Jonathan, I know you've got a couple of points on this, but it appears that with the studies that they've cited here on this first page, that normal scapular movement is quite a large range, and it's sort of hard to objectively define what normal movement is in the scapula. Jonathan, you kind of want to elaborate on that a little bit?
Yeah, I think one important thing to bring up as well is when researchers try and attempt to measure these things, it's very difficult to actually get an accurate picture, first of all, of because the scapular moves in all three planes. That's a methodological, is that a word? A challenge for researchers to, identify the true motion of the scapula. But with that being said, one of the topics that always comes up is the idea of like, scapulohumeral rhythm, and that's a ratio presented, and it just means, how much the scapula moves in reference to how much the humerus is also moving in terms of like upward rotation and humeral elevation. And I know in class we kind of have that 2-to-1 ratio that's taught in kinesiology, et cetera. But it seems like, the evidence is showing that, there's really large variances in the scapulohumeral rhythm, all the way from like a 1-to-1 ratio up to 6-to-1. That's what's presented in this article. So that's just kind of the first point. And all of these things will depend on things like the external load, speed of movement, fatigue, pain. So there's a lot of variables that go into, how the scapula is moving depending on the context. That's just one sort of area where you're going to see sort of what may be dyskinesis, but really just a factor that depends on, or something that's going to change depending on the factors, the external factors.
Mm-hmm. To a 6-to-1 ratio. That's a huge range. And I think one of the things to keep in mind is that within these samples that these researchers pull, they have these outliers, or they have these, extremes on either end of this bell curve. And what they're trying to do is describe an average. So what a clinician might actually deem as abnormal may be normal. It's just an outlier within that range, whatever sample that they're trying to describe from. Does that kind of make sense what I'm saying? Do you all get it?
Definitely.
Yeah. So with that being understood, it becomes very difficult to objectively describe what normal scapular movement is, and thusly it becomes difficult to describe what scapular stability is outside of this definition. And it kind of seems like this definition has been sort of butchered in a way to kind of mean normal movement. But if we can't define normal movement, then how can we define stability in terms of the scapulothoracic joint? And the authors bring up a point here. It's on page 1165 on the left-hand side, where they discuss the concept of robustness. And they tie that into the scapula as like an energy transfer system. And I think, John, you wanted to discuss that a little bit. But in regards to robustness, the article defines robustness as a system's tolerance to uncertainty. And they argue this is probably a better way to describe the scapulothoracic joint, because robustness allows for variability and different degrees of movement or degrees of freedom within the scapula. So instead of this stability thing being like a stable versus unstable, robustness allows for those degrees of freedom. So I think that probably more accurately describes the scapula. And I don't know, what do you all's take on that?
Yeah, absolutely.
All right.
Did you want me to talk a little bit about the energy transfer thing, or?
Yeah, if you have a couple points on it, go for it.
I don't know. I don't want to go too much into the other topics that we have, but a lot of times, like we said, it seems like the scapula is presented as having to be a stable base that should just be kind of unmoving. Think of a solid floor or something, rather than standing on like a balance board or whatever. And this article kind of says that it may be more accurate to conceptualize the scapulothoracic joint as an energy transfer system rather than an anatomical structural base of support, because it's made, the soft tissues are what's holding the scapula in place. So it may be more accurate to define its function as providing a means by which the arm can reach its necessary positions and transfer the energy in the arm to the rest of the body. So it's kind of a more general and broad term, I guess, than our typical base that we kind of are presented with. That makes sense.
Yeah, and it seems like that description of the scapula then satisfies this definition of robustness. If it was just a stable versus an unstable joint, I don't think the scapula would be able to perform those myriad of functions that it can, or those myriad of positions that it can, to allow the hand and the upper extremity to achieve all these different positions.
Right.
Yeah. And then one more thing I want to talk about in terms of definitions. One term that gets thrown around a lot, and Jonathan, you mentioned it earlier, is this idea of dyskinesia. which is defined as abnormality of or impairment in normal voluntary movement. But, as we've seen, if we can't really define what normal movement is, how then can we define what abnormal movement is? And, if we keep that in mind, dyskinesia becomes sort of muddied, and it's an ambiguous term that might not actually mean anything. So, you could term a scapular movement as dyskinetic, but my argument would be that maybe it's just an adaptation that the person has developed to specific task completion prior to seeing you. It might just be representative of normal kinematic movement, just within that wide range of what we term as normal, right?
One of the things, too, that just popped into mind with that is the thing with the scapula, we think of abnormal movement as putting a joint at risk, right? Or like compensatory movements as causing like more impingement, say in the hip. But with the scapula, the way it functions, because it's not an actual fixed joint, it's going to have the variations in movement are to be expected a lot more than something like the hip. And so when you talk about that sort of compensatory movement in a particular individual, just to kind of reiterate what we were talking about earlier about those variations, it's much more. It makes a lot more sense with the scapula that is not a pathological adaptation, right? Because it's capable of moving in so many planes. So just kind of wanted to touch on that again.
Yeah, for sure. Jonathan, you got anything?
Yeah, I mean, it seems as if sort of this connection between, I think this is where we're going with this, right? This connection between dyskinesia and pathology is like not very well established, if that's where we're kind of headed with this in the clinic. So something that I like that the authors point out is that we in terms of like all the kinematic data we have on what's normal variability in scapular motion, it seems as if they say that the dyskinesia is sort of lost in the average, right? But when it's observed in the clinic in one individual, we tend to sort of latch onto that and kind of determine it as problematic, where it may just be sort of an abnormality in any one individual's motion. Sort of like the authors also talk about how people have we accept that people have individual gaits that we kind of latch onto less, and we kind of accept like you can kind of identify how someone walks just based on their gait, or kind of they have an identifying characteristic. So yeah, we kind of tend to find scapular dyskinesis as problematic when that link is not necessarily well established.
Yeah, and I think it goes back to the idea of like, if I don't know how you would objectively describe dyskinesis. Like,
Right.
I don't know a way that you could test that and measure it. And the authors point out, it's on page 1165 again. It's one of the middle paragraphs, and they start out with they're talking about points of how dyskinesia has become an indicator of instability clinically. And they go on to say, quote, second, a theoretical connection among dyskinesia, scapular instability, and shoulder pathology has become widely accepted without clear evidence that such a connection exists. And in the paragraph before, they bring up a really interesting point, and I sort of touched on it earlier, but this dyskinesia or this abnormal movement may actually be a reflection of the nervous system's ability to sort of adapt to different movement patterns, or just to kind of achieve or complete a certain task. So like I was saying earlier, it may just be a representation of an adaptation that person has developed to complete tasks coming to see you. I think the example that I could think of is like a baseball pitcher. They're likely to have different scapular kinematics on their pitching arm than they are in their non-pitching arm. But does that mean that it's abnormal, or that it's a favorable adaptation that helps them throw faster? And within that same page, they go on to state, quote, overall, these reviews do not support a consistent connection between scapular kinematic changes, or dyskinesia, and shoulder impingement, suggesting dyskinesia could develop in response to pain rather than cause it. I think that's a really interesting point. What are y'all's thoughts on that?
Yeah, that's something that really jumped out to me with this paper, just because, intuitively, and how we learn in class, there's this idea that, the scapula has to upwardly rotate, or the humerus, the humeral head is going to run into the acromion, and you'll have bone on bone, contact, which is going to cause high amounts of pain. And it's just interesting that that's not necessarily well established. It's something that intuitively makes sense, but it seems as if, we'll talk about more of the literature on subacromial impingement, I suppose, in a little bit, but it's just interesting that is not, as substantiated as it's presented often.
Do you want to touch on that a little more, Jonathan? I think that kind of brings up a point about, you had a note about individuals with different scapular kinematics may not have too many differences with pain-free individuals. Or do you want to wait to talk about that later?
We can. Do you have anything else, or is that where we're going, Sean? Or did you want to talk about a little bit about kind of the dynamic systems theory? I mean, you kind of touched on that really with your...
Yeah, I think it'll come back up as our discussion goes. I just want to emphasize the point that this idea that somehow, abnormal movement or dyskinesia equals instability equals pain is not substantiated. And it seems like that this is a chicken versus egg scenario that, this quote unquote dyskinesia could cause pain or the pain could cause the dyskinesia. And I think through observation alone and clinical examination, it's unlikely to be teased out. So I would just really want to emphasize that and just keep that in mind because, this term gets thrown around a lot and I don't know how much good it's doing us in clinic and in class. So
yeah, and furthermore, we're relating dyskinesia and pain in some way, but I think it's also important to remember that a lot of people are going to have something that would maybe classically termed as dyskinesis, but are in no pain at all, right? They're completely asymptomatic. And I just had like a quick anecdote on that. We're all sort of weightlifters. We like barbell sports here. And my girlfriend has a coach, a weightlifting coach, who has, he told me one day, he's like, I have a winging scapula. So he took off his shirt and did sort of this bilateral humeral elevation sort of, and showed me, and he actually did have a true, as his right went up, the lateral border, I think Sean wanted to talk about the winging scapula a little bit, did sort of have a true wing, and then as he reached overhead, all was good. But that individual wasn't in any pain and was, high level weightlifting. So I think, I would be, hard pressed to tell him that he needs to work on, sort of specific exercises to change his scapular kinematics because he's highly functioning, to his most specific task and pain-free, which is just an anecdote, but I think it does speak to kind of what we're talking about here.
On the list of buzzwords that I hear either in class or that I've heard in observation, scapular winging has got to be one of the more popular ones that I've heard in talking about the shoulder. And I just really want to emphasize this point. Scapular winging is the result of a neurological injury to the long thoracic nerve. If you do not have a lesion or a palsy of the long thoracic nerve, you are not clinically diagnosed with a winging scapula. I just want to make that point very, very clear. And to throw that around like it's just a descriptor of what the scapular does, I don't think that does a patient any benefit. Because if you tell a patient that they have a winging scapula and they go home and Google that,
yeah,
like that just looks like a recipe for something like a really, really terrible meal. And that was a horrible analogy. But you see what I'm getting at is that we need to be really careful with our semantics and we need to be careful with how we describe normal versus abnormal shoulder movement. I think the authors really emphasize that in this paper, but I'm going to step off my soapbox real quick and let y'all go for it.
That's a good point as to why these semantics in our definitions are important, because obviously if we use something kind of vaguely, like you said, the patient goes and looks it up or whatever, they have an incomplete understanding of it, that's going to affect how their treatment's going to progress, if they're going to respond to it. We know placebo and all that, or patient expectation plays a role in their treatment. So I mean, that's kind of where it becomes clear that the definitions we use do matter in the actual treatment sense, not just in our kind of, being kind of anal about everything.
Yeah.
Sure. Yeah, well, how it does get tossed around though in the clinic, as far as like PT diagnoses come up. I mean, do you think that PTs are sending people on their way with a, PT diagnosis or movement diagnosis of scapular winging? I would imagine, abnormal scapular kinematics probably comes up as well. So that's a good point.
Well, I mean, it's something that they attempt to treat through isolated exercises, serratus exercises and lower trap exercises specifically. But, therein, again, I would ask the question, if it's not a problem, why would you try to treat it? Because I know in class we've had examples where we've used students as like, as they raise their arm into scaption, their medial border's popping up. got to do something to fix it. You got a weak serratus, and it's like, well, these people don't have shoulder pain. Why are we looking for problems that aren't there, right?
Yeah, maybe I should backtrack on my anecdote and say, I think I used the word he had a true ringing scapula. Maybe that was not the right term to use. Maybe he just had a apparent, medial border shift in his, scapular elevation. But a true ringing scapula, it seems like you're right. That's not necessarily the term to be using. I mean, maybe he does, maybe he doesn't. But
yeah.
I think that's a good sort of segue into this because you talked about how often in PT treatment, and I know John has a lot to say on this, but I just wanted to point out the differences as far as what the data says. In treatment, just Sean, you were saying how a lot of PTs or clinicians will target like specific scapular exercises, right? Like target the low traps, target the serratus, etc. To get a more favorable upward rotation or whatever it is that they're trying to augment. The clinician is. And I just wanted to point out, like on page 1166, it seems that the data is showing us that there's really no differences in muscle activation through EMG studies in individuals with subacromial impingement versus asymptomatic populations. Kind of furthermore from that, it also seems that individuals with a diagnosis of subacromial impingement don't show any really consistent differences in their kinematics compared to pain-free individuals. So some may demonstrate more upward rotation, some may demonstrate less. There's just, like we've been talking about this whole time, there's these really large variances in regular scapular movement in individuals with a diagnosis of subacromial impingement and asymptomatic populations. So this kind of just comes back to that chicken or the egg thing,
Yeah.
That's another thing I just want to kind of touch on too, is we always talk about that as, like Sean was saying, we talk about the dyskinesis as causing the pain, versus obviously we know that with pain and whatnot, you have muscle guarding, you have different stuff, and that may be what plays a role into the dyskinesia, like that because in some of the articles, like in the older article that we're reviewing, talks about how there is enough data to show that there's a correlation between scapular dyskinesis and impingement. But obviously we can't know for sure if there's different confounding variables that might play a role into that. Maybe it's something else with overhead work that causes some sort of injury or something that and that is what causes them to guard, move the scapula differently to kind of make up for that and try to avoid the pain, right? So we just need to be mindful of that when we're reviewing studies and kind of coming to conclusions.
Yeah, definitely. Also looking at like sort of their outcome measures, their methods, all that stuff, because even this article cites some scapular stabilization programs as having a positive effect, reducing pain and improving function, but we know that could just come from a regular regression to the mean, kind of coming back to baseline as a tissue insult heals, gets better over time. So you got to, like you're saying, really look at the evidence and see if it's, what it's actually, go beyond the abstract, if you will. What the outcome measures were, et cetera.
Yeah. And we'll touch on this more later. What you're kind of saying there with the scapular exercises may just be causing regression to the mean. By that, I just want to clarify by that, you're kind of meaning you may just be giving the injured tissue, you're working kind of surrounding area, which gives the injured tissue in a different area enough time to heal, basically. So you're just resting one part of the body and working another part, which may be what's causing the increased outcomes rather than an actual change in kinematics.
Yeah, I think from my understanding of regression to the mean, that's just sort of implying that individuals who are either or large amounts of pain, sort of on an outlier perspective, with time, typically tend to come back to baseline, right? Like if we look at the classic curve.
Yeah, bell curve, and I've got the definition right here. In statistics, regressions toward or to the mean is a phenomenon that if a variable is extreme on its first measurement, it will tend to be closer to the average on its second measurement. So when we talk about pain, not pain, let me be careful with this. When we talk about something like a subacromial impingement syndrome or condition, I think that's more a reflection of its natural history. It just kind of gets better as you give it time, because the body's pretty damn good at taking care of itself. You just kind of have to give it stimulus to just to promote tissue adaptation. So, but I second the points that you guys are talking about. I really think there is a regression to the mean here, and definitely a reflection. This is definitely a reflection of the injury's natural history. So it kind of begs the question, like, are these individualized, super specific muscle isolation exercises really doing anything? Yeah, they might be helping the patient get a little bit stronger, but I don't think they're actually treating the pain per se or the tissue injury per se. What do y'all think about that?
I mean, just from what we've looked at, probably not. Yeah, and more importantly, if it's taking away time from exercises we could be doing to help them achieve function faster, it may be detrimental. Obviously, they may have a place, which I'll talk about later, but in general, prescribing them as a be-all, end-all, or as the initial thing that we do for patients with scapular dyskinesis is probably flawed.
Yeah.
Yeah, it seems like the evidence is pretty clear on the stabilization programs having an effect or not on specific muscle activation. Like once again, got another study cited in this article showing in patients with subacromial impingement syndrome, matched with the control group, found no differences in muscle activation. So just kind of another.
I just found this point in the article. If I could interrupt for a second, we're talking about exercise programs to sort of fix dyskinesia, but the authors bring up an interesting point that a lot of these studies, from a plausibility standpoint, may not be valid just because, quote, the fact that scapular dyskinesia is a poor predictor of shoulder pain may kind of confound the idea that, oh, we're going to fix this dyskinesia and help your pain. Yep. So again, it comes to like, what are we actually fixing and what are we actually doing?
Right.
Just something to keep in mind. But, this article is pretty clear that there's little evidence to suggest that specific scapular motor training or pattern training through individual muscle exercises is a good way to go about fixing this whole scapular stability paradigm. So with that in mind, how do we train the scapula then? How do we train this system of soft tissue and muscle structures?
Squat, bench, deadlift, snatch, clean and jerk. No, I'm just kidding.
Go ahead. Not TheraBand external rotations?
Maybe.
What color?
What you got, John?
Okay, so yeah, I just want to talk a little bit about the treatment like we were talking about. Just to go off of Sean's point where he talks about global kind of versus localized treatment. One good point in the article, it says, where it talks about where is the evidence leading us and on what should we focus. So it's saying that we probably don't need to change too much. Is my video cutting out? Okay.
Yeah, you're good.
It's saying we probably don't need to change too much of necessarily how we treat them, but we should change kind of our thought process when we're developing individualized exercise programs. So it talks about how the, scapulothoracic joint is located proximally, and the muscles that control movement are innervated by the ventromedial descending motor control system. This descending system has limited potential for precise voluntary control of the individual muscles it recruits, and instead organizes activation into more global synergy. So it's suggesting that focusing on these very specific isolated exercises is probably not going to have a very big effect on the final result in a more functional movement which incorporates multiple joints. So we should be focusing probably more on what the patient needs to do, their function, and then figuring out what's appropriate based on that, right? So obviously some of these exercises we do may have a role, like I was talking about earlier. If the patient we have, has tissue that's very irritable, so we can't do tasks that might seem more functional, such as, flexion, overhead stuff, we might need to give that area a rest and work on something we can do, in which case maybe some scapular stabilization exercises would be appropriate. But applying that as a whole as our ideal treatment to the entire patient population that presents with some sort of dyskinesis is probably flawed when it's based on this model of dyskinesis being the primary problem. The exercises themselves may have a place, but since the evidence is so vague, we can't use that as a blanket statement for directing everything. What do you guys think about that?
I think you nailed it, really.
Yeah, I agree. And the authors actually bring up a concept, and they have a study cited here. Let me find it real quick. It's, let me guess. Yep, it's on 1165 again. It's that middle paragraph, and they talk about dynamic systems theory. And I have a very rudimentary understanding of it from glazing over the article that they cited there. But the gist of what I got from it is that task completion or activity completion is a function of the individual, the task, and the environment in which the task is completed. And that's something that we touched on in a couple of our classes, John. I think keeping that in mind is probably going to be more effective to getting the patient back to an appropriate functional level when it comes to their pain or to their disability than trying to tease out, oh, your serratus is the reason you have dyskinesia, which is the reason why you have pain, so let's train that. It's probably better to train the whole system as a system.
Right.
And the authors actually bring up a really interesting point that I want to sort of expand on. This is on page 1167 at the top right-hand paragraph. Quote, the scapula in all likelihood is subservient to the hand for most tasks. I think that's a really interesting concept. Y'all have any thoughts on that?
You have anything, Jonathan?
Honestly, maybe I didn't necessarily grasp what that was saying until now. Is it suggesting that the scapula is not necessarily a base for the hand to move on, but something that moves as a result of upper extremity motion? Is that sort of the hypothesis there? Or?
That's what it would appear to be, based on what John's quote said earlier too. When they talk about the ventromedial descending motor control system,
yeah,
and how it has a limited potential for precise voluntary control of the individual muscles it recruits. Yeah. So it organizes it globally. So the scapular movement may be a result of this idea that it's trying to get into the position that optimizes the function of the hand. Yeah. Or, sort of leverages that. But go ahead, John.
Sorry, I didn't mean to cut you off. So it talks about that right after the paragraph that I quoted. It says, from a motor control perspective, the position of the scapula and its equilibrium very likely are low priorities for the central nervous system. Instead, movement, planning, and execution are focused on the hand and how it will interact with the environment to complete a specific task. And so that's definitely suggesting, where the hand is trying to go, that's where the scapula kind of moves to accommodate that in a way. It's not like it's there, it forms a base, and then the hand goes. It's the hand's reaching, the scapula moves to position it where it needs to be.
Yeah, I think an important caveat just to throw in there that we've been talking about is there's a million ways, or not a million, but there's a multitude of ways that the scapula may move to accomplish that task as well, right? So we're not looking for one particular movement where the scapula is, completely in the most optimal position. It's just sort of seems, what's the word? Very variable, right?
What's the term for that, Jonathan? How are we going to define that?
I'm sorry?
How are we defining that? What is the term associated for what you just described?
Pectoralis minor?
That would be motor redundancy.
Okay.
Motor redundancy. So, just so we're all on the same page. Sorry, I'm just giving you shit.
I'm laughing at myself.
No, motor redundancy. For a given task, the central nervous system is able to produce an infinite combination of movements to achieve that task. So, yeah, man, I think you just described what that is, and that kind of sums up how the scapula moves and what its purpose is, in my opinion.
Right. So by that, how would that look in treatment, I guess? Would we just, I kind of know, I have an idea of it in my head that we would basically focus on, like, the functional task, and maybe we'd break it down to a lower level, and then obviously if we're actually having the scapula have some sort of problem with it, we can focus on how the scapula assists that action.
Yeah.
What do you guys think as far as
I agree. I think taking a top-down approach to it is probably one of the better ways to go about doing it. I've had discussions with professors and classmates about this, how they prefer to go about treatment in clinic. And I've asked them, like, do you prefer a bottoms-up approach or a top-down? I think it varies clinician to clinician, but it seems to me that a top-down approach, and what I mean by that is trying to incorporate exercises that are the most specific exercises that you can do relative to whatever that functional goal of the patient is. So, for example, if you've got a weightlifter that comes in and they have pain when they're snatching, and you don't want them to snatch, do the next best thing that is as close to snatching that you can get them to do. So maybe an overhead squat or a snatch grip push press, something like that. So I think, not arguably, but one of the better ways to go about treating it, in my opinion, is to think about, what the patient does on a daily basis, how they go about doing it, when they experience pain in doing that, and then try to create a program or pick exercises that are reflective of what they're trying to get back to. And if the most you can do is banded external rotations and you have to regress it that far, that's fine. But in my opinion, I think it would be best to start with something as specific to the activity they're trying to do as you can.
The only time that I think a not only, but one time that I think a bottoms-up approach may be necessary or favorable is like post-op, right?
Post-op,
You kind of have to follow some progression, and that makes sense. Yeah, but if I think what you're saying is, if someone comes in, let's say they're an athlete, let's say they're an Olympic weightlifter, and they have shoulder pain, it's probably not your best idea to put them on the TheraBand, right? Like we should probably try and regress them just like you're suggesting. A variation as close to as possible to their most specific task, but that result in less pain or something they can complete, just so they can still get a training stimulus.
Yeah.
Yeah, that definitely would be a little more complicated when the patient comes in. They don't have any particular goal or task. I mean, obviously, we try to model that, like we talk about in class. Let's say their occupation can be something as simple as playing with their grandkids or whatever, which can become difficult when we're trying to model treatment off of what they're doing. But
pick up the crate off the ground, right? That's perfect. Right. Yeah, I think maybe that just kind of comes down to how the patient interview goes, right? Kind of identifying good goals and things you can. I mean, that's huge.
So if you guys don't mind, real quick, one thing that I thought of when you talk about the motor redundancy is how one part in the article talks about like how, for example, upward rotation can be achieved through a lot of different, I guess, force vectors of the different muscles. Do you want to talk about that a little bit, or is that kind of not necessary at this point? I thought it was a pretty cool point, but
no, I think it's an interesting point too. Go ahead and give a little spiel on that.
Let me find the spot in the article.
I think it's 1165.
Starts on 1163, I think. It says.
Ah, damn it.
Okay.
No, you're right. Correct.
This is another misleading belief is that muscle force balance plays a role in creating dynamic scapular stability or equilibrium. For dynamic stability to be achieved, synergistic muscles are not required to be balanced in terms of their activation or force generated. The idea of multiple competing forces in a system is illustrated in the figure they give, and the upper trapezius muscle force doesn't have to be equalized or balanced with the lower trapezius or serratus anterior muscle in producing upward rotation movement on the scapula. So the idea that I'm envisioning and kind of what it's presented a lot is that, okay, let's say your upper trap is tight and it's causing a weird pulling on the system that's going to unbalance everything, and suddenly your scapula is going to be dyskinetic or whatever, right? This is suggesting that's not the case. The muscles and the total, I guess, force doesn't necessarily have to be equal, as long as it says, rather, all that is required is the net moment satisfies the Newtonian condition for dynamic equilibrium. This condition represents a state of dynamic rotational equilibrium or stability. So for that, my understanding is that we just need to have forces that can cause whatever rotary component we're trying to achieve, rather than like, okay, the upper trap is pulling, this amount, lower trap has to pull the equal amount.
Just so long as the net vector is in the direction that you want it to go, right?
Exactly. And the direction is probably more important based on if we're thinking of a rotary component, which obviously the scapula is more complex than that because it doesn't have a fixed axis. But it's still going to show that it's not as simple as, okay, your upper trap, it's not quite as simple as we're thinking, right?
Yeah. And they bring up a really interesting point in regards to the different periscapular muscle moment arms. And they're saying that this idea of, trying to create this system. The common cue that I hear is like shoulders back and down, like put your shoulder blades in your back pocket. That's kind of what I hear when it comes to just cueing static stability. So you hear like pull them down and back and lock them in place.
Yeah.
But they're saying that what's up?
Just lock them in. I'm just laughing.
Yeah. It's interesting because they make a point that that might actually be inefficient in terms of trying to optimize the function of those periscapular muscles. And like John was talking about, I'll just go on and read the sentence after the quote he finished. Quote, because the muscles have different moment arms and thus different mechanical advantages for causing angular rotation in the joint. So locking the scapula in place may not actually be leveraging these different muscles' moment arms as optimally as you could. And they go on to cite an EMG study that talks about how if a muscle is at its, best moment or longest moment arm, I think it's longest moment arm, or has the best mechanical advantage, then its EMG activity is likely to be low. So you may actually see a situation where these muscles may appear like they're not firing as strongly as they could be, but that's just because they may have the best mechanical advantage at that point wherever the scapula is.
And do you have something, Jonathan, or do you mind if I jump in real quick?
No, go for it.
So that's a really good point, Sean, how you're talking about how cueing something specific like shoulders back and down may actually be counterproductive because assuming that the shoulder is, one thing the article mentions is as the scapular position changes, the moment arms of all the different muscles changes accordingly, right? Because obviously now the scapula is shaped oddly and it's going to cause varying moment arms. So that's if you're trying to consciously cue something like, let's say, lower trap activation kind of consistently throughout the entire movement, that's not going to allow for those natural variations that have to occur to allow proper positioning so that the hand can move. So we're actually probably trying to have that conscious control could very well be a bad thing. Because right here in the article, it says if a muscle at a particular degree of motion has a mechanical advantage because of its moment arm, its motor unit activation's requirement will be low. That's what Sean was talking about. Let's see. And it says, confounding the issue is the fact that because the scapula both translate and rotates in 3 dimensions, its instantaneous axis of rotation is constantly changing, affecting the moment that each scapular muscle can generate and rotate the scapula, right? So, I mean, our body kind of has built-in things to, obviously, the nervous system and whatnot, to appropriately position the scapula for best movement. And so if we're trying to cue that, something that's against that may be detrimental. I just keep repeating myself, sorry.
Well, it's interesting you bring that up. Trying to find it real quick. But, I mean, we were going over some special tests yesterday, and that just kind of stuck out to me as like one of the special tests that we were going over for the scapula was, I think it was the scapular reposition test, McClure's test or something, whichever one it is to cue lower trap firing as you assist the scapula in like posterior tilt and upward rotation. But it's like that may not actually be, holding aside the plausibility of like if you're actually doing anything there, but that may not actually be optimal for what the scapula needs to do or muscle activation for getting the scapula into that upward rotation position.
Yeah, absolutely. And there's so many different muscles that play a role in that, in the force couples that rotate the scapula, that kind of trying to consciously control them, not taking individual, there's so many individual variances like we're mentioning with the article, so many variations that occur during scapular movement. To take all that into account and assume we can just give a blanket statement of, get your lower trap going is.
But John, the test is, it works if you don't have pain. It's a positive test if you don't have pain. It does its job. So how do you explain that?
I can't think about that right now. It's still too early in the morning for me.
Sensitivity, specificity? No. I think it's hard to say that there's no instance where you might want to train any muscle group. Like let's say the trap, whatever it is. I think it's just kind of like you're saying, you're avoiding these blanket statements that it's always one particular muscle. And I don't know how. Maybe it's something we should look into more. Just kind of food for thought. How you would identify that the low trap needs to be trained over some other scapular.
It's clinical observation, Jonathan.
Yeah.
Like, you just don't have a trained eye.
You
just haven't been practicing long enough. Your experience is lacking.
You haven't incorporating that in your lifting routine, have you, Jonathan?
Probably why. That's probably why. So where are we going from here? I mean, I think it kind of all comes down to this, injuries. We talk about this a lot. Injuries are just a result of tissue overload. I don't know if you guys want to go here with like kind of just talking about graded exposure and function, but in my opinion, we can build tolerance to any position in training, right? So rather focusing, it just seems like I don't want to repeat myself too much, but rather than focusing on changing the kinematics of the scapula, we want to focus on increasing function, specific tasks through graded exposure, right? With a top-down approach, ideally. So
absolutely,
that's where we are. Are we going to talk about the other article? I feel like it kind of just acted as an adjunct to our discussion. I don't know if we need to dive into it too much. What do you guys think?
Yeah, I mean, I think it kind of represents a paradigm shift. That's one of the things I liked about it. Is that conveniently, both of these articles were authored and co-authored by the same person. So it kind of shows how this idea of scapular stability or just normal scapular kinematics has changed over time. But the concerning thing is that, the more ancient, if you will, of the two articles is in our textbook. Yeah. Right. So, I mean, I understand that these things don't get updated maybe as well as they should, but I'd be hard pressed to find anybody outside of us three that I know of that would go and actually check the references from the textbook to see what the articles are talking about. So I worry that the data that they pull and put in the textbook and cite with this study will just be taken at face value and just like, oh, if your kinematics are off or you have dyskinesia, you got to stretch your pec minor, that sort of thing.
I mean, the data, like I think we're all perfectly happy with. I think it's really comes down to the discussion around the data that kind of changes. It's all about the narrative, because I mean, if we want to talk about the data in this particular paper, they looked at individuals with shorts versus long, and we can get into that if we want to, pec minors, but it really seemed like it didn't have a huge difference on scapular kinematics. It kind of comes down to how the authors go about discussing their thoughts, or in the discussion section of the paper. I feel like that's kind of the data is the data.
Mm-hmm. Yeah, and just having read through it already, it looks like the only time that the data was significantly different, which I don't think they provided effect sizes for it either, but anyway, the data was different was with scapular internal rotation and the amount of posterior tipping, but there wasn't a difference between the short versus long groups in terms of upward rotation, which I think is kind of interesting.
And I'd also like to point out, just for the sake of anyone who doesn't have this paper in front of them, that the largest difference, so you can determine if this is clinically significant or not, but the largest difference they found was, somewhere in the realm of 10 degrees. 10 degrees difference was like the biggest difference they found in scapular internal rotation. Yeah. So, I mean, and the rest, all the other significant differences they found were less than that. So, whether that's clinically significant or not, I don't have a test for, but just something to bring up.
Yeah.
Let's take a look at the, I'm looking here at the scapular tipping where it talks about, and let's see, the biggest difference there is
10.5 looks like. Yeah. That's internal rotation, excuse me.
Very good. It's not quite 10 degrees, I think. Yeah, so that's
10.4 for scapular plane elevation and for scapular.
Yeah. And coronal plane is 9.1 for scapular tipping, for that difference between long and short.
Yeah.
Yep. So, yeah, and note that there was really super insignificant differences in upward rotation, which is really what most people tend to latch onto.
Yeah.
Through the serratus and the lower trap and all the upward rotators.
I think they defined what they considered a clinically significant change or a clinically significant difference. I want to say it was 5 degrees from a prior study that they cited, but I don't know where I highlighted that. I'm trying to find it.
Let's see if I can do a search for it.
Did you pull that up? Sorry.
No, go for it. If you got any points you want to bring up, go for it. I'm just going to keep looking for this.
Right. I mean, even if it's just hard to say that the pec minor is really a limiting factor. I mean, it's tough because we are identifying there's so many variances in scapular kinematics. Who knows? I don't know. I can't remember the subject criteria exactly, but depending on these individuals, hobbies, their exercise habits, their, I don't know, anthropometrics, anything, their scapular kinematics, we understand, are going to be very highly variable between individuals. So to say that it's maybe a result of the length of the pec minor, I mean, I understand for the sake of research, the research question, why they would ask that. It seems to me like probably not a target for clinical intervention, the pec minor.
Yeah.
All these things are just going to be sort of variable to begin with.
Yeah, and in our discussions that we've had prior to recording this, I mean, John brought up the point too that their initial average calculation that they got was from a subject pool of 6 people, I think, and they compared it to cadavers in terms of like validating whether or not they could actually measure the pec minor through palpation.
Right.
So that in of itself is kind of dubious, or a little bit strange to me, suspicious.
Yeah, so they just clarify on that further. They basically took 6 people to establish their short and the long groups. They took pec minor length compared with height, and just 6 people to establish what was long versus short. And that's pretty crazy. I mean, especially if we're talking about what's normal or whatever, right? And we're just using a sample size of 6. I mean, for the actual study, they used a lot more people. Just established what was short versus what was long. It wasn't a good measure.
Yeah, and I'm looking through the methods again because I want to see. I don't recall them saying that they cued anything from the subjects, but I'm just wondering, even if the Pec minor actually had an effect on this, or was something that we could change. I just wonder how much benefit you could get through maybe cueing like thoracic extension, or just kind of pushing your chest up and out to sort of offset that anterior tipping. Or
talking about in their static posture, they said they had a procedure for trying to eradicate that, where they took several measurements and they didn't tell the subjects when they were measuring, because I think it was all through like a visual system. So they attempted to have the most accurate depiction of their just normal posture. But, once again, like, that's not – how do we know that that's really descriptive of the pec minor length? That could just be muscle stretch, man. Muscles move.
Yeah, that's true. Right. Not to mention that mocap tends to be – it's as accurate as we can get it, but it's still kind of iffy sometimes, so –
especially, again, for the scapula, with it being so highly variable and not a fixed joint, moving in 3 planes, that's going to affect a lot of stuff. So
yeah.
And another important point in the article is just that the people with the short pec minor and the altered kinematics didn't have any pain, right? So the article mentions that, hey, they're not overhead athletes, so maybe that's why they haven't accessed those range of motion.
Yeah.
Pain. But, I mean, still, it's probably, for a majority of people, it's probably not actually going to affect their function. I mean...
Yeah, I feel like this data just kind of confirms everything we're talking about, right? In my opinion, that there's these variances in scapular kinematics. And without repeating ourselves too much, any final thoughts on the kind of like where we're going with this whole, maybe treatment or scapular stabilization, dyskinesis?
I mean, I thought we hit it pretty well when we were discussing the perspective paper. I mean, just remembering the importance of semantics and, viewing the patient as a whole rather than several parts that you're trying to treat through different exercises. Right. It seems very simple when you put it like that, but I really think that's the crux of it.
Shoulder series, part 1.
Dyskinesia.
Time.
Ooh.
And that about does it for episode 2. If you have any questions or comments, you can shoot us an email that's linked below. We can also be found on YouTube, Spotify, and SoundCloud at Beyond the Abstract, and you can follow us on Instagram at BTA Podcast. Thanks again for tuning in, everyone, and we'll see you next time.